Next, we have Dr. Sharmila Devi, a faculty from RIO, and she is the Joint Secretary of Tamil Nadu Ophthalmic Association, the past editor also of the official journal of Tamil Nadu. And she will be talking about the blunt trauma to eye.
Good morning, everyone. At the outset, I would committee and the Chief Instructor, Dr. Mamta, for making me part of this session. My topic is management of ocular blunt trauma. And I think some of the points were highlighted by Dr. Deepak Mishra. Ocular trauma is a leading cause of monoocular blindness, and it's very important because it's preventable. And it's more common in males and the pediatric pediatric age group, and 50% under 40 years of age. It's preventable blindness, and that's why it's been given more importance. History taking is very important, history and documentation. Why? Because we might be attending the ocular trauma, and there might be a concomitant life-threatening injury which might be missed. So it's very important to know about the nature of trauma, the nature of the inciting object, and the past ocular history is also very important, whether the patient had any refractory error and any other ocular complication. And the type of composition of intraocular foreign body, that is also very important. I think this classification was touched upon by Dr. Deepak Mishra. So what are we looking at? The questions that we should ask, and the findings that we should look for is there an eye wall defect? If so, it is an open globe injury. If there is no eye wall defect, then it's a closed globe trauma. In a closed globe trauma, again, is there a partial thickness defect? Then it becomes a yes. Then it becomes, if there is no partial thickness defect, then it becomes a contusion. And if there is a defect, it becomes a lamellar laceration. And was the injuring object blunt or sharp? If it is blunt, it is called a globe rupture. And if it is sharp, it is called a laceration. And laceration, you have the penetrating injury and the perforating injury, which was explained in detail by Dr. Deepak. And this is the comprehensive classification. It is given in Birmingham Eye Trauma Terminology System, or the BET system. And this is what we should use for classifying ocular trauma, and prognostication should be done by ocular trauma scoring. And this is very important because this was proposed based on the Birmingham Eye Trauma Registry and the Hungarian Trauma Registry. And this ocular trauma score can be used to give the prognosis to the patient, whether after repair, whether the patient will have a good prognosis or a bad prognosis. So most commonly what we see is a periocular hematoma, and it's important to exclude the fractures. It can trauma to the globe orbit, all types of fractures, roof, basal skull, and blowout. And sometimes patients can present with a proptosis with retrobulbar hemorrhage and with increased intraocular pressure. And then you might have to do a cantholysis to prevent damage to the optic nerve. So I'll not be touching much on orbit. I'll restrict myself to anterior segment. So what are the suspicious signs following trauma? You can have circumcorneal congestion. And in closed globe trauma, you can have injury to the iris or the ciliary body vessels, and you can have hyphema. And the rest were touched upon by Dr. Deepak. You can have iridodialysis and all kinds of lens-induced complications. You can have a subluxated lens, you can have a dislocated lens, you can have an anterior lens capsule breach and an early cataract. You can have an incomplete or a complete osseous ring. And most of the time, the patients present to you later after a closed globe trauma. The telltale sign can be a sphincter tear. So please look for the sphincter tear, and these patients can present to you with a late post-traumatic glaucoma, iridodialysis. So on examination, when you see a hemorrhagic emesis, you should think about an occult scleral tear. Sometimes you can have DM folds. So the DM folds can be due to contusion, or it can be due to hypotony. So it's very important to know whether the DM folds are because of hypotony or just because of contusion. And then the rest of it you should be documenting as per the guidelines. And what is the most commonest anterior segment complication which you can have following a closed globe trauma? It's high intraocular pressure. So the early onset can be due to trabeculitis or traumatic hyphema. And when do you call it a post-traumatic glaucoma? When the baseline intraocular pressure. What we are looking at is the baseline intraocular pressure. It should be over 21 millimeters of mercury. And if you're treating the patient for 3 months, then you call it a post-traumatic glaucoma. The late onset causes can be angle recession, ghost cell glaucoma, lens-induced glaucoma. Peripheral anterior synechiae can cause closure of cyclodialysis cleft and suprachoroidal hemorrhage. I'll be touching upon this later. So you're looking at different types of hyphema. It's very important to grade the hyphema, especially for postgraduates, and document it properly. Why is it important? Because the treatment guidelines are based on that. So the first two pictures, the microhyphema and the grade 1, you can just observe and put them on a conservative management. Grade 2 and grade 3, you probably need to record the intraocular pressure and take a call based on the intraocular pressure. The intraocular pressure recording in a closed globe trauma is done using a rebound tonometry, that is an IK tonometer. Grade 3 and grade 4, it's better to take them for paracentesis. And you should always remember the 8-ball high femur, which is like a favorite question for examiners. So what are the indications for surgery? If their intraocular pressure is 60 millimeters of mercury for 2 days, 50 millimeters of mercury for 5 days, or 35 millimeters of mercury for 7 days, then definitely you have to take the patient for a paracentesis and remove the blood clot. And for sickle cell disease, you need to have a very low threshold, because in sickle cell disease, even if there is an intraocular pressure of 25 millimeters of mercury for more than 24 hours, it can damage the optic nerve. So you have to have a low threshold for sickle cell disease and take the patient earlier for surgical management if the intraocular pressure is about 25 millimeters of mercury. Why should you intervene? Otherwise, what will happen? Not only damage to the optic nerve, but you can also have a corneal blood staining. Late post-traumatic glaucoma, Gossa's glaucoma can be a cause. So what happens here? You have a vitreous hemorrhage, you have the RBCs in the vitreous cavity which undergo morphological, rheological changes. So the biconvex red RBCs become spherical, hollow or khaki colored, and they become less pliable. And microscopically, you can also see the Haynes bodies. So these are Gauss cells, and that is the Candy stripe sign, which again is a examiner's question. So what you have in the Candy stripe sign is you have a streak of fresh blood layered over khaki colored hyperpion, and that's a very pathognomonic sign for Gossa's glaucoma. So Gossa's glaucoma happens only when there is a tear in the anterior hyaloid face. So how do you manage this? I think Dr. Shweta touched upon it. Topical and systemic anti-glaucoma medications. You avoid pilocarpine here because it can cause inflammation, and PG analogs are not indicated. So you start off with beta blockers, brimonidine, and topical carbonic anhydrase inhibitors. It's important to avoid carbonic anhydrase inhibitors in sickle cell disease, as it can cause acidosis and it can increase the sickling. And AC lavage, we've already spoken about it. For Gossa's glaucoma, it's essential to do a vitrectomy also. And most of these cases are intractable glaucomas, and they definitely need a trab with a pharmacological modulation, especially with the mitomycin C or ologen. And sometimes you might have to do a tube also for them. So that is a case of hemophilia. This patient had a very trivial trauma and he had undergone a paracentesis also. But you can see the blood staining of cornea because the intraocular pressure was not properly monitored and managed. So it's very essential to properly document the intraocular pressure and manage it accordingly. So this patient underwent a triple procedure, penetrating keratoplasty with intraocular lens. You can also do a DSEC with cataractous lens if needed, removal if needed. Angle recession glaucoma is again an important cause of post-traumatic glaucoma. Now, what is angle recession? It is just a disruption of the longitudinal from the circular fibers of the ciliary body. Now, that's a misnomer. That is not going to cause glaucoma. It's only the trabecular scarring of fibrosis which is going to cause the glaucoma. So, what do you see? On gonioscopy, you see a broadened ciliary body band. And then whenever you have an angle recession glaucoma, you should make sure the patient comes to you for follow-up regularly because it can present with a late onset glaucoma. You definitely need to do an ultrasound biomicroscopy. I think the rest of the investigations were covered. You have to do a CT orbit, X-ray orbit to rule out presence of any foreign body and bony fractures. Sometimes you have to do an USG for assessment of posterior segment, and ultrasound biomicroscopy is very important in post-traumatic glaucomas. You have this angle recession. That's the second picture is a cyclodialysis cleft where you have a separation from the scleral spur. Why is cyclodialysis important? Because this paper gives you the predictors for the development of traumatic glaucomas. This paper is from RP Center by Dr. Ramanjit Shihota et al. So what are the parameters to say that these patients are prone for post-traumatic glaucomas? One is increased pigmentation of the angle. Another one is elevated baseline intraocular pressure, high femur, lens displacement, angle recession of more than 180 degree. These are all positive predictors for the development of traumatic glaucomas. On UBM, if you have a wider angle and the absence of cyclodialysis, they are not very significant. That is what the paper concluded. So what you see here is a shallow anterior chamber with the cyclodialysis cleft on gonioscopy, and the patient has a hypotony maculopathy. So any patient with a low intraocular pressure, please check the posterior segment for hypotony maculopathy and do gonioscopy and a UBM. So why is this important? Because later stages, the cyclodialysis cleft can close and then the pressure can raise. But then, according to the paper, it's not a very important predictor for the development of post-traumatic glaucoma. Now, I'll show you some mimics. This is also closed globe trauma. But then if you look at it very closely, you can see all the DM folds. But if you look at it very closely, you can see this white spot. Okay, so if you get the history from this patient, this was a 12th standard boy who was just riding a two-wheeler, and then something fell on his eye and he just rubbed it. So it's just a trivial trauma. But then actually what happened is it's an insect stinger. And then I just have 30 seconds more. So it's just an insect stinger, and that insect stinger has caused a kind of an allergic reaction. So that insect stinger was removed and the patient was put on anti-allergics, and intracameral antibiotics also was given, and the anterior chamber was formed, and the patient is doing very well. And pediatric cases, you definitely, even in closed globe trauma, you have to put the patient under examination and anesthesia, or at least sedation, and look for, do a double eversion, because this patient was a firecracker injury. She was not doing very well even with adequate treatment. And then when we did an EUA, we found a incense stick which was used to light the firecracker that was behind the lid. So it's very important to do a proper evaluation case of pediatric cases, because they'll be crying incessantly and you won't feel like examining them, and you might miss a lot of these points. So eversion and examination and anesthesia is very important for pediatric cases. And this paper in IGO was for ban on firecracker injuries, because firecracker injuries can present to you with a lot of post-traumatic glaucomas, closed globe trauma and later post-traumatic glaucomas. Secondary prayer of intraocular trauma, I think it was touched upon by Dr. Deepak. So cataract extraction, definitely at some point you have to do it. So you have to plan it whether you want to do it early or later, and what type of, you have to assess the posterior segment and UBM properly before doing it. Posterior segment evaluation also has to be done, because these eyes are prone for commercial retinae, choroidal tears and RDs, and intraocular pressure also has to be done frequently.